Inside your arteries right now, blood is rushing at high speeds. In this high-pressure environment, a single microscopic traffic jam can cause a fatal cardiac event in seconds. When that rushing river of fluids suddenly slams to a halt, the clock on tissue survival starts ticking immediately. Because blood moves so fast through these arterial highways, standard slow-building clotting mechanisms fail. They get washed away. The primary culprits behind these rapid arterial jams are platelets, sticky, disc-shaped cell fragments that constantly patrol the bloodstream looking for damage. When these platelets sense trouble, internal chemical triggers like calcium, ADP, and TXA2 initiate a biological superglue protocol. TXA2, or thromboxane A2, is a potent signal that causes platelets to become highly adhesive. These chemicals force the platelet's surface receptors to physically change shape, allowing them to morph and interlock with neighboring cells. Once those receptors lock together, they bind tightly with fibrinogen. Fibrinogen is a soluble protein in blood plasma that converts into a solid, thread-like mesh during clotting. This mesh cements the cellular traffic jam into a solid, impenetrable wall that completely blocks arterial flow. Surviving this volatile, high-speed environment requires a proactive defense. Doctors deploy a class of drugs known as antiplatelets, essentially chemical artery guards. Their sole mission is to intercept the internal triggers and prevent the cells from ever becoming sticky in the first place. You likely have the most famous of these artery guards sitting in your medicine cabinet right now. Aspirin is widely known as a basic household painkiller, but its cardiovascular utility is far more targeted. For over a century, it has been the foundational weapon in the medical arsenal. Aspirin executes a specific maneuver inside the blood. It permanently jams the COX enzyme inside the platelet. The COX enzyme is a critical protein responsible for synthesizing the chemical signals that lead to clotting. By disabling this gear, aspirin eliminates the platelet's ability to manufacture that TXA2 superglue. Cardiologists prescribe aspirin using a specific low-dose strategy, typically between 75 and 300 milligrams. This small amount is calculated to selectively target and neutralize the sensitive platelets without disrupting the body's other necessary chemical functions. This minimal dose has a massive chemical payoff. While the platelets are disarmed, the healthy blood vessel walls are left intact to continue producing PGI2, or prostacyclin. PGI2 is a beneficial lipid that forces blood vessels to dilate and actively repels passing platelets. Aspirin's efficacy lies in this chemical manipulation. By disarming the sticky platelets while allowing the vessel walls to continuously pump out repellent, it shifts the local environment heavily in favor of smooth, unobstructed blood flow. Standard guards like aspirin work well for average circulation, but they are insufficient for patients facing higher-risk cardiovascular scenarios. When the biological panic gets too high, a single chemical blockade fails. The ultimate high-risk scenario occurs when patients require artificial mechanical interventions. The hard, unnatural surfaces of metallic cages and synthetic heart valves trigger the body's defense mechanisms, resulting in massive, rapid platelet aggregation. To protect patients with these artificial valves, doctors deployed dipyridamole. This specialized guard works by raising internal CAMP levels within the platelets. CAMP is a critical messenger molecule inside cells that regulates various functions, including the suppression of calcium. By keeping calcium low, dipyridamole calms the platelets and keeps them moving past the synthetic metal. When patients have complex heart disease, doctors might turn to clopidogrel. This weapon operates on an entirely different trigger path. It permanently shuts down the platelet's ADP receptors, neutralizing another major avenue the body uses to signal a clotting cascade. For patients facing imminent unstable heart attacks, single drugs are swapped for a synergistic action protocol. By administering clopidogrel alongside aspirin, cardiologists create an overlapping defense net. One drug stops the COX enzyme, the other shuts down the ADP receptors, leaving the platelets with almost no way to clump together. As the structural environment of the heart becomes more complex or artificial, the body's clotting instincts become aggressively hyperactive. Outsmarting those instincts requires layering these chemical therapies to attack multiple biological pathways simultaneously. Sometimes the preventative guards fail entirely. A massive clot forms, a major artery is completely blocked, and the patient is actively having a heart attack. At this stage, prevention is useless. The medical team is now fighting a terrifying ticking clock. They have a critical window of exactly 30 to 90 minutes. If they do not intervene and restore blood flow within that time frame, the starved heart tissue will permanently die. They deploy the chemical SWAT team, fibrinolytics. These drugs have a single violent purpose. They flood the system to trigger the creation of plasmin. Plasmin is an aggressive enzyme that degrades blood plasma proteins. It is deployed specifically to actively eat through the clot structural mesh and destroy the blockade. The first weapon in this class is streptokinase. It has a unique ability to bypass the blood's natural inhibitors and attack the clot at maximum potency. However, because it is derived from bacteria, it carries a severe risk of triggering massive allergic reactions in the patient. If a patient has a bacterial infection or has been exposed to streptokinase before, doctors pivot to an engineered alternative called Alteplase. Alteplase is a synthetic tissue plasminogen activator created through genetic engineering. It achieves the same clot-busting results without the risk of an allergic response. These fibrinolytic drugs rescue dying tissue with brute force. They are an aggressive, final intervention, deployed by emergency teams in a desperate chemical race against cellular death. Using the fibrinolytic SWAT team carries a terrifying risk. While these drugs are effective at melting the lethal clot in the heart, their mechanism can easily and quickly trigger a catastrophic, unstoppable systemic bleeding event throughout the rest of the patient's body. This forces cardiologists to navigate the ultimate medical paradox, the fine balance. They must operate on a razor-thin mathematical line. Undertreating the patient leaves a fatal blockage in the artery, but overtreating them causes a fatal hemorrhage. Surviving this balance requires mapping drugs to 3 tactical zones: anticoagulants for slow veins, antiplatelets for fast arteries, and fibrinolytics for acute blockages. Selecting the right family means matching fluid dynamics to the medication, letting speed and location dictate the weapon of choice. Pharmacology is a high-stakes, real-time tactical war. Every prescription is a calculated maneuver to preserve the human body's most fragile and vital equilibrium,